Our next speaker is Dan Claw. Dan is Professor of Medicine at the University of Michigan and Director of Chronic Pain and Fatigue Research Center. He's Director of the Michigan Institute for Clinical and Health Research at Ann Arbor. He received his medical degree at Ann Arbor. He was a resident and fellow at Georgetown, started his academic career at Georgetown before going back to Michigan. He's co-editor of Arthritis and Rheumatism and Arthritis and Research and Therapy. He's published over 250 papers, reviews, and book chapters, and he's going to talk about the role of CNS amplification in musculoskeletal pain, implications for treatment, and rehabilitation.
Thanks, David. It's fun to be back here. So this is the topic that David gave me, but I'm a contrarian, so I renamed my talk. So I am going to talk about fibromyalgia today, but I'm really going to allude to fibromyalgia more as a metaphor, as a construct, rather than as a standalone disease. I think that I've been in the fibromyalgia field for about 20 years, and in the broader pain field, that is certainly the way fibromyalgia is now viewed. It went from being the stepchild of a pain syndrome that no one could figure out to a syndrome that I'm going to try to convince you that we actually understand fairly well now, at least as well as a lot of other diseases that we're much more comfortable by and large in treating. And again, I will talk about it as a standalone diagnosis, but I'm going to also talk about some really recent insights into how important this construct is for any chronic pain state, not just people that you might say have quote-unquote fibromyalgia. So these are two different people's knee x-rays. If you're at a rheumatology conference, most of you are quite familiar with looking at knee radiographs. Which of these individuals is experiencing pain, the one on the left or the one on the right? So you're supposed to say the one on the right. That's the right answer on the boards. However, osteoarthritis is one of the pain syndromes that has been dramatically impacted by our emerging notion about so-called centralization of pain and the fact that whether you want to call it, say that OA patients sometimes centralize their pain, that they sometimes have comorbid fibromyalgia. I don't really care what words you use to describe it. The centralization term is generally better accepted in many circles than the fibromyalgia term. But again, I'm going to talk about what we know biologically and what we know about the construct and leave the term to you. We've known forever that there's a terrible relationship between what we see on an x-ray in someone with purported knee OA and whether the person's experiencing pain and how severe the pain is going to be. And many, many, many studies have shown what I'm saying here, and that is that if you look at people in the general population, 30 to 40% of people in the general US population that have a knee radiograph like that person on the right, bone on bone in one of their joint spaces, Kellgren-Lawrence grade 3, Kellgren-Lawrence grade 4, 30 or 40% of those people have no pain. And 10 to 20% of people who have severe knee pain have normal knee radiographs. Now, this isn't as clinically apparent as it is when you're a researcher, because you don't often do knee x-rays in people who don't have any pain. So you don't really appreciate how poor the relationship is between a radiograph and the presence or absence of pain unless and until you look at some of the population-based studies where you take everyone and you do x-rays in everyone. The condition that you'd be most familiar with how poor the relationship between imaging studies is and pain is would be low back pain. You all know how abysmal the relationship between MRI findings or CAT scan findings and the presence or absence of pain is. But I'll tell you today that this is true of every disease. There's not a single chronic pain state where anything we can measure out in the periphery, X-ray, MRI, for the subspecialists that have scopes and put scopes into organs. It doesn't matter. Oscopies never relate well to whether the person is experiencing pain and or how severe the pain is going to be. So we always have this disparity between what we see out in the periphery and what someone's experiencing with respect to pain. In OA, just like in every other pain syndrome where we see this disparity between radiographic or MRI features and whether someone's experiencing pain or not,